Our last speaker for this session is Dr. Kaneko, presenting virtual biopsy with integration of MRI for prostate cancer risk stratification.
Good morning, everyone. My name is Masatoma Kaneko from USC. Thank you for the opportunity to present today. The current standard of prostate MRI reading is PIRADS, but PIRADS system has several limitations. It does not provide patient-specific prediction for significant cancer. The sensitivity of PIRADS system is high, however, still misses 10% of significant cancer. Relatively high false positive rate may lead to unnecessary biopsies and high diagnostic costs. Another limitation is inter-reader variability. In fact, PIRADS score agreement is only 50 to 60%. Here is an example of inter-reader variability in PIRADS system. This MRI was interpreted as PIRADS 5 at outside institution. However, the case was eventually reassigned to PIRADS 2 through internal review. Such a significant discrepancy could affect patient care. Also, radiologist human factors has limitations, including the need for expertise, radiologist workload, exhaustion, and burnout. To overcome these limitations of prostate MRI reading, the use of AI is a promising idea because AI may contribute to objectivity, faster diagnosis, lower cost, reduced workload, human errors, and education for trainees. We propose pAI-RADS, Prostate Artificial Intelligence Imaging and Reporting Data System, a concept to incorporate AI-powered prostate MRI and non-invasive clinical parameters for prostate cancer detection. Our ultimate goal is to achieve accurate prostate cancer diagnosis through precise AI-powered image analysis, eliminating the need for invasive biopsies. We are developing an AI model to detect and characterize clinically significant prostate cancer on MRI. Here shown is our multidisciplinary team consisted of engineers, urologists, radiologists, and pathologists to develop AI model. In the next few slides, the challenges of AI in healthcare will be overviewed. Certain types of AI are described as black box. Black box natures of AI can exist in training process and data set, inference process, and its output. For example, if training process and data set are not clear, the results cannot be reproducible, therefore unreliable. Also, inference process, specifically of deep learning model, is black box because it includes complex interactions and vast number of layer structures, parameters, and extracted features without physical meaning. Furthermore, the final model is subject to randomness. And output without supporting information have issue for explainability. Such black box nature of AI are not explainable, and therefore it makes challenging to incorporate into the clinical decision-making process. Contrary, the preferred features for explainable AI include a transparent training process and data set, and simple and interpretable structures for inference process, and output with supporting informations. Such explainability of AI is a foundation for responsible clinical decision-making. Sustainability is an important topic for AI. Since the advent of large-scale deep learning models, training for state-of-the-art AI requires double the computing power every 3.4 months. According to the Semiconductor Research Consortium, the total energy consumption for computing is doubling every 3 years. This growth far exceeds the global energy production rate. Clearly, a shift toward energy-efficient, lightweight AI model is essential to address this disparity. Another consideration is cloud versus edge computing in healthcare. Current trend is cloud computing, which use remote servers hosted on the internet to store, process, and analyze data, providing powerful computing resources on demand. However, processing sensitive patient data in the cloud can raise concerns about security and regulatory compliance. Alternatively, edge computing process data by local computations. Edge computing has several advantages, include conserving network and computing resources, reducing operational costs and latency, and enhancing data security and privacy. However, it requires lightweight machine learning model due to the limited computational power at the edge. To address these unmet needs for AI in healthcare, we designed transparent data-driven lightweight radiomic AI model, green learning. Green learning is characterized by low power consumption, small model size, high performance, and efficient training process, and high interpretability. Automated workflow of green learning AI includes automated segmentation, ROI detection, and ROI reclassification. From our prospectively maintained prostate biopsy database, 755 pre-biopsy MRI was identified. The MRIs included 18% of outside MRI images as well. As ground truth data, zonal segmentation was done on T2W images, and region segmentation was done on biparametric images. Histological label for the regions were assigned based on targeted biopsy results. Here shown are the patient characteristics of our cohort. Black, Latino, Asian people accounted for 30%. The diversity of race and ethnicity is one of the strengths of our dataset. Automated segmentation. After pre-processing, green learning AI extract imaging features to segment whole prostate and zonal anatomy. This is a demonstration video of our web-based segmentation green learning software interface. Once the T2W images is uploaded to the local server, the prostate is immediately segmented, as shown. DICE score as measure of the overlappment between ground truth segmentation and automated segmentation were 0.91 for whole prostate, and the correlation coefficient for the volume was 0.9. This excellent performance of our green learning model is comparable to state-of-the-art deep learning models. Next, AI detects region of interest. After feature extraction and selection, AI generates per voxel probability as a heat map. Here shown is a demonstration video for automated ROI detection functionality. AI automatically generates an MRI readout which describes prostate size, volume, and PSA density. It also describes the prostate cancer suspicious region. Once a lesion is selected in the heat map, the lesion's location, size, volume, and significant cancer probability score is reported. Per patient, the AI detected patients with clinical significant prostate cancer lesion of interest by AUC of 0.8. When combined with clinical data, the combination model achieved well-balanced performance with an AUC of 0.9 and sensitivity of 93% and specificity of 85%. Lastly, AI reclassifies PIRADS 3 to 5 index region into negative versus positive for clinical significant cancer. After feature concatenations, AI classifies index region. As you can see, AI probability score between grade group 2 or higher versus grade group 1 or benign cases were separated. And reclassification performance of AI was AUC of 0.85. For patients specifically with PIRADS 3 lesions, 53% of targeted biopsy could be safely avoided using this AI model. On multivariable analysis, AI probability score, PSA density, and PIRADS were independent predictors for significant cancer identification. Combination of these predictors achieved excellent discriminant performance with AUC of 0.93, sensitivity of 86%, and specificity of 90%. On open source dataset, Green Learning achieved comparable performance to deep learning models with an order of magnitude fewer model size. Recently, a large multicentric retrospective study comparing AI and radiologists was published from Lancet. In this study, 5 deep learning AI models were pre-selected from pAI challenge competition. And the ensemble of these deep learning models was compared with experienced radiologists in detecting clinical significant cancer on MRI. In comparison, AI versus 62 experienced radiologists with limited access to clinical data, case level AUC of AI was significantly superior to those of radiologists. AI detected 7% more significant cancer at the same specificity as radiologists, and 50% fewer false positive and 20% fewer insignificant cancer detection at the same sensitivity as radiologists. In comparison between AI versus radiologists in clinical routine practice, radiologists had full access to patient history and peer consultation. In this setting, AI did not show non-inferiority to radiologists, although the observed gap in specificity was only 0.1%. To interpret this result, AI is comparable to radiologists in clinical routine practice, and the inclusion of comprehensive clinical information into AI may further improve its performance. This well-designed study provided important evidence for AI-assisted MRI reading, but there are some limitations which need to be addressed in future studies. Most important limitation is a retrospective study design, which relies on prostate biopsy yield. Also, there was a potential data bias. Although AI has demonstrated comparable performance to experienced radiologists in retrospective studies, an important question remains whether AI-assisted diagnosis has added benefit over an expert radiologist MRI reading. This prospective study assessed the inter-reader agreement of AI-assisted PIRADS scoring by novice and expert radiologists. Interestingly, the agreement in PIRADS score with the expert radiologist improved in 2 novice radiologists with AI-assisted, but decreased in the remaining 2 novice radiologists by the AI assistance. Furthermore, the use of AI actually increased the MRI reading time. Another prospective study also assessed the impact of the clinical implementation of AI-powered prostate MRI reading. Again, no significant improvement was observed in workflow, throughput time, workload, and stress with the implementation of AI. So far, the clinical usefulness of AI-assisted MRI reading has not been proven in prospective studies. In conclusion, AI-powered MRI evaluation shows promising performance in detecting clinical significant prostate cancer in the retrospective studies. However, transparency, energy consumption, and model size of AI should be carefully considered. The added benefit of clinical implementation of AI for prostate MRI has not been proven. As a next step, prospective studies and non-biased data are required to demonstrate the clinical utility of AI-assisted MRI reading. That's all. Thank you.
I think that was a wonderful session. As we see the promise of AI and its integration into our clinical practice, I have one question. My radiologists are really trying to get their clinical version to help with their workload. But the data, can someone speak to what a clinically significant cancer is in the AI world? Because it appears to me that it's 0.5 cc's or larger when they identify size. And how do you separate volume from grade? Because we all know large volume lesions are much easier to identify for people and the computers. Any of the speakers? Because for Quantinib, they set a threshold for their AUC is 0.5 cc's. I think there's challenges with inter-reader variability, but how do we square that up? Because you're seeing numbers that appear 90%. Oh, how do we speak to that? Can any of the speakers? You heard this talk. Who wants to go buy an AI unit to read your prostate MRI? Like, it's really promising.
Should we bring the speakers?
Yes, the first speaker.
We welcome the speakers.
Can he come up?
Dr. Kaneko. Please come.
Well,
and
my
you can
focus.
ask questions and you can debate. Please come. Dr. Kero, please.
Yeah, I think you bring a very important point.
Rakesh.
Rakesh, yeah.
It's going to really depend on your ground truth and who's determining what your ground truth is going to be. A lot of these AI algorithms are being built on like we say, the visible cancer in the MRI, and actually not even incorporating histopathology. So this consensus needs to be reached, and I don't think we're there yet.
But how do we comment on this? Because for the general urologist or the regular radiologist, this appears to be a workflow enhancement. And how is your team, like this poor guy has to deal with me a lot, but how does your team square up a 0.5 or not 0.5 cc lesion as clinically significant? And what are we doing with between 7 and 1 centimeter and the 4 millimeter lesions? Is that clinically significant? Those are visual disease. Dr. Emberton would say if it's a visualized cancer, that should be addressed, but you're given a false sense of overperformance or overestimation of the performance of the model. Dr. Carroll, Rakesh?
Let me just mention that what urologists define as clinically significant is by grade. We've dichotomized prostate cancer, and it's flawed. So at least I showed you 20% of unfavorable intermediate risk cancers are low risk, and actually when you go to favorable intermediate risk cancers, at least 1/3 are. So again, I think the real problem is this operational definition. Volume does count, so volume does count. But I think urology's got to go consider. That's why I think this grade group 1 not cancer is flawed, because it ignores the fact that many higher risk cancers are actually favorable risk. So it's actually a spectrum of disease.
Yeah, I mean, we've had this argument several times, haven't we? And it's circular. But we do. If we need a new definition, I think we probably do, because we're struggling with the grade group 2 or more, because it doesn't get us anywhere. A dynamic definition, so borrowing from lung cancer lesions, might be something that will serve us well. So, a clinically significant lesion is a lesion that you can see that is a cancer that grows over time. So radiological progression over a given time might discriminate lesions in the short term that are significant versus not. So we need a near-time proxy to make a decision on therapy rather than a kind of baseline. And with imaging now, we have that opportunity, and you can do it, automatically. So you detect a lesion and then repeat the MRI a year later or 6 months later, and if it grows by greater than 30%, you've got a proliferating progressive lesion. That might be an important biological attribute that predicts the future. And that would be completely new and revolutionary, because everything is based on baseline risk.
So, but how do we square up what's happening in the AI market? If you buy a system, you can't fine tune that to your MRI. It comes pre-packaged, and there's a limitation there as well. Can you speak to that?
Into this as well, you alluded for different patients, race, ethnicities. There was one of your slides. So most of this data generated with Caucasians in somewhere else, and they just sell this FDA approved to be used in everybody. So if you can put both together.
That's what I'm trying to make the point here, Rakesh, because you don't realize that this is what's happening, and you're going to have a tool that's not really going to perform as what you've been told.
Yeah, so when it comes to the resolution, then, I mean, I don't have an answer. So we need to pick our problem, and right now, we focus on lesions that are discernible. So the resolution of MRI, just allows you to do as much. So until and unless we have very good quality images, then I don't think we'll be able to, with confidence, say these are clinically significant. So my answer would be improve image quality and then train models on improved quality. But as you mentioned about the point about we need to calibrate the models. So models that come off the market, I have been working with Art, and we built a model based off of a public data set. And when we tested it on his data, it just completely failed. So we need to calibrate those models for specific populations, for specific sites, and we need to work with a number of institutions and put that data out there. So I think absolutely we do need to focus on specific populations, specific scanners, and AI is brittle. That's one of the impediments to clinical translation.
Dr. Feller?
Yeah, for Dr. Kaneko and those that are developing algorithms that are using biopsy as ground truth, I'm interested in how you're defining normal, right? I mean, unless you have whole mount radical prostatectomy specimens, it seems like there's a problem with how you would define normal in the algorithm development and avoid a lot of false positives.
Yeah, this is you can talk as well, but it's a limitation of most of the data sets. It's based on biopsies. The biopsies many times underperformed. They are not really biopsies has errors. It's a limitation by sampling. And sometimes the biopsy itself is a poor technique or quality. And we build this entire data based on things that are not reliable from the get-go. That's what Dr. Kerr is showing, that he has this repository comparing prostatectomies, actually whole mount with MRIs. And I don't know if he wants to comment on this. I think that's what we should do, but in a prospective way and larger data sets, not only one center. It should be multi-center. That's my thing. But.
My question is, when we originally defined significant cancer, it was defined from memory as a 1.3 cubic centimeter Gleason 6 tumor or 0.5 centimeter Gleason 7 tumor or above. And I think that was based on, and I could be incorrect, biochemical recurrence post-radical prostatectomy or unfavorable characteristics at radical prostatectomy. And so if we go to a moving field where we're monitoring the tumor over a period of time, such as Mark's suggesting, and then have a redefinition of what significance is, it's the end point that we need to actually look at to see what makes it significant. And so what do you think the end point should be? Should it be biochemical recurrence? Should it be unfavorable disease on histopathology? What's the end point that gives you significance if you want to look at baseline characteristics?
The end point is actually moving because, the FDA wants hard data. So and we were in this early on, predicting adverse pathology is thought to be kind of a weak endpoint. I can tell for grade group 1, volume does not seem to be a predictor. So high volume grade group 1, even though it's a risk for progression on biopsy over time, it has no impact on outcome after surgery. So I think the 1.3 centimeter definition is going to go away. So.
I have a question here. Oh, yeah, sorry.
I just wanted to make a comment. I've worked with quite a few engineering teams on developing these AI models, and it's just important to realize that these neural networks are functionally optimization exercises. They're optimizing for an outcome. So when we're talking to the engineers trying to build these things, it's really important that we agree on what the outcome is. It's really hard to train an AI system to agree with people more than people agree with people. So it doesn't necessarily matter that you have a perfect outcome or that we all that it's the best outcome ever, but it's really important that we agree with each other on something. And we release that to the engineers so that they can optimize their neural networks for that outcome.
Thanks, Tom. I think we're going to bring this session to a close, but we have come up with one key thing from this meeting is that we're going to work with the FDA to come up with definitions of what an optimal focal therapy candidate should be, so we can have those building blocks for better trial design in the future, as well as secondary outcomes that could get us to the end of the road on validating this approach. And with that, I'd like to thank the speakers for putting the time in, amazing talks, and the questions. And please go to the vendors, try to sign up for the raffle if you like, and look forward to the next session. Thank you very much.